Well, thank you. The previous presentation reminded me about how much further ahead other areas of medicine are compared to psychiatry with respect to the development of precision medicine approaches. Nevertheless, although I'll talk about some of the reasons why psychiatry has lagged, I'll also talk about some more encouraging ways that we're making at least some small steps toward precision medicine approaches. I oversee the development of new treatments for depression at Janssen, where I'm a full-time employee. But I wanted to mention that several of the projects that I'll mention today have been funded by public-private funding sources and are part of consortia or academic collaborations, including two that we have here with Mel McGinnis at University of Michigan. Although we're not making, or one of the manifestations of not making progress in precision medicine is that as a ranking of the global burden of disease, mental illness is continuing to climb. As we're making progress in infectious disease, cardiovascular medicine, other disorders, it's becoming more of a problem for mental disorders. For major depressive disorder specifically, which is what I'll talk about, this remains the leading cause worldwide of years lost with disability. In addition, you have major depressive disorder as the leading antecedent or causal factor for suicide. Another manifestation where suicide rates have continued to climb, especially for my demographic and also for adolescent girls, where in many developed countries this is now the leading cause of mortality. One of the reasons why we haven't made more dent in these statistics with our current approaches is that about a third of patients are unable to respond to existing treatments. And an even bigger problem is among patients who do respond, if you follow them for just a year, most will relapse despite continuing to adhere to treatment. In addition, the antidepressants we have take a minimum of 3 weeks to become effective, and so they're not very useful when you're managing acutely suicidal patients. In other areas of medicine, they have dealt with treatment resistance and with propensity to relapse by combining mechanisms of action that are distinct or by switching to other drugs that have novel mechanisms of action. And in psychiatry, though, we haven't made very much progress since the 1950s in terms of coming up with new treatments that have novel mechanisms of action. So although we've had a proliferation in incremental changes within the same mechanisms, they're not very useful when you just cycle through the same mechanism for patients that are treatment resistant. Some of the reasons we've had difficulty coming up with new targets for drug discovery has been that we still don't understand the etiology or pathogenesis of our conditions. In addition, because we don't know pathophysiology well, we still define our nosology using clinical signs and symptoms that are relatively non-specific. And we don't have, although we recognize that our conditions are heterogeneous, we don't have precision medicine approaches yet to identify who among those patients is likely to respond to some mechanistically distinct treatment. At Janssen, we've tried to improve upon this using relatively crude approaches for precision medicine by subtyping based upon clinically observable phenotypes. So in one case, pharmacological responsiveness has been one, so I'll talk about the development of esketamine for treatment-resistant depression, and we'll actually walk through this one as an approach for how you determine that a novel mechanism actually can be useful over the long term in such patients and in a way that prevents relapse. Another approach has been to take symptom domains such as suicidality or anhedonia, and which often persist despite current treatment, and then to develop treatment specific for those. And I'll just briefly touch on these by way of examples. We're also increasingly working with using biomarkers of inflammation and metabolism to identify subgroups that we think will ultimately turn out to be responsive to medicines with primary immune mechanisms or other types of mechanisms. And then finally, I'll just briefly mention some of the technology-based and informatics-enabled solutions that we're generating to try to get to more true precision medicine approaches where we predict depressive relapse in individual patients, where we quantify risk factors and symptoms of relapse, and then where we identify biomarker signatures to predict treatment. Although we haven't made much progress in terms of understanding pathophysiology, at least our conditions are removable by drugs. And so we have identified some antidepressant drugs with partly by serendipity based upon what has changed the major depressive syndrome. And I'll talk about one case, esketamine, where we've taken advantage of an academic observation along these lines. We also know, based on biomarker and neuroimaging and other types of studies, the circuits in homeostatic systems that are affected in depression. And in many cases, we have evidence of their importance based upon induced depressive syndromes, where you can get classical major depressive episodes induced by elevated glucocorticoid exposure in Cushing's disease or interferon alpha exposure, and I'll talk about one of those as an example. We're also learning about the cellular and neurotransmitter systems that will move these systems and circuits in their function in ways that either will exacerbate depressive symptoms or induce them de novo, or will conversely have antidepressant effects. And so that's beginning to also guide us to new therapies. In contrast, we haven't been able to take advantage very well of the genetic findings, because although it's clear that mood disorders are heritable, nevertheless, the findings so far from GWAS studies and other types of genetic studies have shown that these are conditions that have daunting polygenicity, and so we have not yet found actionable targets from those kinds of studies. This is an example of the finding I mentioned about ketamine, that in academic studies it was shown that sub-anesthetic doses of intravenous ketamine would produce an antidepressant effect in people who were treatment resistant to monoamine-based treatments, and that the effect was both rapid, here shown in a day, and also it persisted well beyond the primary pharmacological action of ketamine. In this case, the antidepressant response is persisting a week. And it's thought that this is determined by neuroplasticity changes that are longer lasting than just the drug action alone. To try to develop a treatment that was more conducive to outpatient psychiatry, we worked with an intranasal formulation of S-ketamine, the S-enantiomer of ketamine. It was at the sub-anesthetic doses where ketamine would produce antidepressant effects. It's relatively selective as an NMDA receptor antagonist, and a variety of clinical and preclinical information suggested that the antidepressant effect depended upon an initial action of NMDA receptor antagonism. Ketamine's a racemate. The S enantiomer has 3 to 4 times greater potency than the R enantiomer, and that turned out to be important for the feasibility of getting enough drug in through the intranasal approach. So consistent with this greater potency, you could match the antidepressant effect shown at 0.5 milligram per kilogram IV of racemic ketamine by using a lower dose, 0.2 milligram per kilogram of S-ketamine. And so we took this PK profile, matched intranasal doses to it, and then we also replicated findings from academic studies that by pulse treatments of twice a week or even weekly, you could maintain the antidepressant effect. And then we developed a long-term treatment strategy to test prior to submission to FDA, in which we have an initial induction phase where you dose twice a week for 4 weeks, followed by an optimization phase where you see whether patients can get by them with weekly, and then subsequently with bi-weekly or every other week treatment. And then once you have optimized the regimen for that patient, then you maintain them on that for a maintenance phase. And then we've now completed phase 3 studies that are both short-term for efficacy and long-term, and I'll just show a couple of the long-term studies for in order to show that these will persistently keep depression in remission in those patients who've been unable to stay in response or remission to biogenic amine-based treatments. In addition, after this initial induction period and optimization, over the course of a year, not only did the antidepressant response remain, but the drug was relatively well tolerated because you have side effects that are limited to the couple-hour period where you've still got a pharmacological action of the drug, but then the rest of the time you spend essentially side effect free. And then also it turned out to appear safe over a one-year treatment period with this pulse regimen. We showed that this has a greater effect at preventing relapse compared to treatment with a biogenic amine-based antidepressant in a study that used a randomized withdrawal design. In which we started with the induction and optimization phase for 16 weeks, and then randomized patients to either remain on both esketamine and the oral antidepressant, or to switch to continuing the oral antidepressant, but then intranasal placebo. And what we were able to show in both patients who were treated initially all the way to remission, which means their depression ratings were in the non-depressed range, or if they were unable to achieve remission but could get to a response, which meant your treatment showed a 50% improvement in a depression rating scale. In both cases, you could show that you had fewer relapses in the group that was maintained on esketamine plus antidepressant versus the group that was maintained on antidepressant alone. And this was especially prominent in the group treated only to response, which has historically been shown in other studies to be a relapse-prone group. And here, esketamine continued to maintain their benefit. To see whether we could take advantage of the rapid antidepressant effect in managing acutely suicidal patients, we conducted a phase 2 study in which we recruited patients with major depressive disorder and suicide ideation who were at imminent risk for suicide, and then treated them to reduce their suicidal ideation. This was beneficial for the acute. The primary outcome was improvement in the MADRS rating scale. The secondary outcome was improvement in suicide ratings, and the study met both endpoints. Finally, we're working with circuits, as I mentioned, that we know will influence systems and symptom domains that are important in depression and that will often persist despite current treatment. And these include individuals who are continuing to manifest anxiety syndromes or symptoms, persistent insomnia, persistent anhedonia, which means the inability to experience pleasure, motivation, interest in previously enjoyed activities. And we've learned in phase 2 studies that you can treat patients with insomnia and depression with an orexin-2 receptor antagonist alone, and so we're pursuing that for adjunctive treatment in depression. We've also learned that a kappa opiate receptor antagonist can specifically work on anhedonia symptoms, and so we're also testing that in phase 2 for that patient subgroup. And then finally, we're experimenting with looking at biomarker signatures that identify inflammation, individuals with chronic inflammation who have, and then testing treatments that have been shown to be beneficial for treating depressive symptoms within the context of inflammatory disorders. And in the course of these, then hope that we can, in fact, advance new mechanisms that will then foster more evidence-based and precision medicine-based approaches in psychiatry. With that, let me stop.